Welcome to Ingest, the podcast series designed for primary care and brought to you by the Primary Care Society for Gastroenterology. I'm Charlie Andrews, a GP with an extended role in gastroenterology based near Bath. I am delighted to have Dr John Leeds here with me again. This is for part 2 of our series about the pancreas. So in this episode, we're going to be talking about malignant pancreatic lesions or conditions. If you haven't already done so, I would highly recommend that you go and have a listen to part 1, where we talk a lot about kind of what the pancreas does, and it will really set the scene for you. And there's so much useful information in that episode talking about chronic pancreatitis, which you might well touch on in this episode, pancreatic insufficiency. So do have a listen to that before you have a listen to this one, if you can. But yeah, absolutely delighted to have you here, John. Do you want to just, for those who perhaps haven't listened to the last episode, could you just introduce yourself again?
Yeah, no worries. I'm John Leeds. I'm a pancreaticobiliary physician and endoscopist. I work at the Freeman in Newcastle and a professor of pancreaticobiliary medicine at Newcastle University.
Brilliant, thank you. So we're going to be focusing here our attention on pancreatic cancer, really. And the first thing I'm going to ask, is just thinking about pancreatic cancer is often diagnosed at quite an advanced stage, unfortunately. What sort of early warning signs could you recommend that primary care clinicians can look out for or be particularly vigilant about that might indicate a malignancy of the pancreas?
Sure. I guess is one of the biggest problems is early detection rather than fast diagnosis. And it's a bit similar to the chronic pancreatitis thing we talked about in the previous podcast, where actually the issue is more around that it's actually really hard to make a diagnosis. It's one of these things that the pancreas is, again, so deep inside you that you coming out behind you before you even get to it. It doesn't press on very much, so things can grow in the pancreas to quite a size and therefore invade other organs before you get any symptoms whatsoever. So particularly tumours of the kind of body and tail, there's a lot of room. These things can grow big and invade all kinds of stuff. And if you think of the blood vessels and things around there, the thing that makes something inoperable is the fact it's usually invaded an artery. Veins, perhaps you can remove some of the veins, but if it started to wrap itself around one of your major arteries, so your celiac axis, your superior mesenteric artery, you can't remove that. That's the blood supply to a pretty huge part of your gut or liver or whatever it might be. So we know that often means it's spread further anyway. Whereas in the head, sometimes you catch it a little early because it takes out the bile ducts, and that's why people present with jaundice. Often, it's very, very close to some of the other quite major structures, and so even if it's done that, it's still often quite late, even in that diagnosis. The earliest one you're ever going to get is right on the ampulla. So imagine right at the bottom of the bile duct. You don't have to have something very big for it. Whacks out the ampulla. That's away from a load of vessels. That's very, very treatable. Unfortunately, they're a minority. So early symptoms, well, there are not that many. What's the other thing I was thinking? There's not really that many. The subtle ones, so early jaundice. Weight loss, again, by the time you're getting weight loss, you've probably got to, most of the symptoms on any of the upper GI referral forms are often those of advanced cancers. We don't have a great early finding. So weight loss, I guess, maybe early PEI, which you sometimes get with pancreatic cancers. The other one people often are interested in is new diabetes. Now, of course, diabetes is really common. As far as I understand it, there's 4 million people in the UK who've got diabetes, something like that. It's a reasonably big number, most of whom will have pretty standard diabetes, your standard, most of which are type 2, obviously. And whilst it's all based on the pancreas, in that case, it's actually based on the fact you've got insulin resistance, isn't it? And your type 1s, well, okay, yes, they get weight loss because they've got insulin deficiency, but normally not in a group that you'd think it'd be a pancreas problem, because they're normally younger people, aren't they? Not everyone, but they'll be younger people. And there's been various studies where they're trying to kind of think, well, just new diabetes increase your, or mean you perhaps, they're a high risk group to look at, and they're not really getting a big yield from that, as I'm sure you imagine. If you took 100 people with new type 2 diabetes, I suspect most of them have just got new type 2 diabetes. But there may be a group of within that, what if someone isn't, got a higher BMI? What if they've got a more normal BMI and developed type 2 diabetes? You've got to think, well, actually, is it type 2? Is it, so maybe you have to think more about that, but no one's really that certain. Early symptoms are often really vague or absent, and I think that's often the problem. So it's your standard kind of upper GI, a bit of dyspepsia, a bit of weight loss. Jaundice is obviously a big red flag symptom. There are many causes of jaundice that aren't serious. We always find that if someone's yellow, we normally find something wrong with them, whether it's the liver, the bile duct, or a tumour or something of that kind of nature. Not a huge number of people, unfortunately. Not a great number of things you can go looking for. It is the golden bullet of pancreatology, which is to find some kind of biomarker or proper high-risk group or strategy to case find these people. Because as with any cancer, the earlier you find this, the better it will be. And the problem with pancreas is it's often very what we call systemic. So often by the time you can see it, it's often actually a lot further on than you realise. And there's been some changes, I think we'll come to this later, but things like PET CT have actually shown, you think you've got a relatively small lesion in your pancreas, and the PET goes and shows actually there's more widespread disease than you realise. Which is why we're moving a bit more towards things like neoadjuvant treatment, because actually there's probably more there than you realise than you can actually see on the CT scan, and that's what that's there for. So unfortunately, we don't have a great number of things to say, yes, look for these things. They're the obvious ones I'm sure you all know about. We are working towards biomarkers. In fact, we're doing a study in Newcastle at the moment looking at the microbiome in the pancreas, which I didn't think there'd be any bugs in your pancreas. Turns out I don't know anything. There absolutely are. And maybe there's a signature within that. We're at a very early stage, but it might be, in the long term, what we end up with is some kind of mouth swab to look at your microbiome, and that maybe gives these the group of people who are at higher risk. Now, they'll not all get it, but these are the ones to look for. These ones we can forget about. Who knows? That's the kind of thing you'd love to have. Or there is no fit test, if you like, for pancreas. That's what you're looking for. CA19-9 is not a screening test. Please don't do it as a screening test. It goes up in all kinds of different things. Same as CEA. They're not useful for those kind of things. They go up in lots of other diseases, and it's unhelpful if it's isolatedly raised. So that's not what they're meant for.
Okay. Yeah, well, really difficult, isn't it? I think I'm casting my mind back to med school days and thinking about painless jaundice and Courvoisier's sign. I think that's it. Have I just made a fool of myself?
No, that's absolutely correct. Yeah, that's a palpable gallbladder. Yeah. There
we go. Got it. Okay, good. I've still got it. So really difficult, isn't it? It's so hard to work this out. So do you think there is a role for screening for pancreatic cancer in high-risk groups? I think you've already mentioned that it's really hard to find out who those high-risk groups are. I mean, I'm wondering about I know that there's interest in finding people who are diabetic and, looking at weight loss in those patients. Is there a role here in case finding? And if so, who would you kind of consider for screening, and how might you do that screening?
Yeah, very good question. So there is something called the EuroPac study, which is run from Liverpool, runs across Europe, because there are some familial versions of this. So that's a group that do get this, but they're quite the minority. So unlike some other tumours, so breast, for example, even colorectal, are really very familiar, or a lot of them are very familial, or hereditary, shall we say. I think it's less than 10% in pancreas cancer that's actually familial. Most of it's sporadic and you're unlucky. So for those who, and there's criteria, so you have to have the right criteria. So if you've got, you've got a family full of people who've had pancreatic cancer, well, that would make you wonder. And there are some genes, and even some of the things like the FAP, familial adenomatous polyposis coli patients, they have an increased risk. So there's a bunch of other underlying genetic and germline tumour mutations that do increase your risk. But again, they're quite the minority of people in general. So we do have a cohort of about 400 patients again in Newcastle area who are under screening or surveillance, or whatever you want to call it, for high risk family members or high risk family history. It's quite stringent. You know, it can't just be your dad had it. You know, you normally have to have several members, and it usually has to be under the age of 60, if not 50, for it to be considered that, because most of these tumours will occur in the 60s and 70s. That's just normal. That's bad luck or whatever you want to call it. So if it's picked up earlier, then that's when you might then think, well, actually, is this familial? They get a combination of different ways of surveying, but usually annual screening, whether that's MRI or CT, or we sometimes use endoscopic ultrasound. Again, the other groups are those with hereditary pancreatitis. They have a significant increased risk. A bit harder to screen because actually the pancreatic change is already there. It's abnormal. And so, you're not. So the first group with the higher risk family, they've got a normal looking pancreas and you're looking for a small blob featuring. Whereas if you've already got chronic pancreatitis because of a gene, your pancreas don't look normal in the first place. So, proper needle in a haystack stuff. And then there's some of the groups like, one of the BRCA mutations is associated with pancreatic cancer, as is FAP, as is things like Pearce-Jaeger's. So there's some other genetic groups. Chronic pancreatitis on its own is one that you probably get an increased risk. It doesn't currently quite meet the criteria for screening for pancreatic cancer. And actually, I think in a lot of those patients, smoking might be to blame for a lot of it. So smoking is a big risk factor for pancreatic cancer, and a lot of patients with chronic pancreatitis smoke. And that alone maybe accounts for a bit more of the increased risk than we realise. So, there's other things you could go looking at for that. And there probably are a few other kind of more random, smaller groups that we look for. Again, partly what we did, and again, it's been in the previous podcast, pancreatic cyst patients, what we're really looking for is tumours. So you've got a cyst and it's a marker that something's not quite right in the pancreas. So you're doing a CT scan or an MR every so often to see if something's growing. But actually, again, that's quite low incidence. So, and it's a slightly different mechanism to screening in other situations. So there are a small group that will do that for. Again, we're back to, if we had a biomarker, that would be the ones to go looking for. So if someone had their pancreatic BLAR test was abnormal, they would either, if they were suitable, maybe they go for surgery early, who knows, or they get very close screening. Well, you've got to remember, if you do lots of CT scans, you'll eventually give someone cancer. So, there's a trade-off here. Plus all the things like we talked about, cysts, incidentalomas, what a nightmare. So every time you do a scan on somebody, yeah, you might pick up the thing you're looking for, but then you find three other things that you think, I've got to now follow up this, lung nodule. They've got something weird in their adrenal, and they've mentioned some weird fatty change in the retroperitoneum. What the heck is all that? So you end up with more people get over-investigated, over-medicalized, and what do they call it? Scanxiety. So you have to, we underestimate the morbidity of telling people, I'll just do a scan again in 6 months. They often sit there thinking, well, I hope it's all right. I hope it's all right. And you as the doctor is thinking, I'm doing that because I think it'll be fine and I've got nothing to worry about. And I'm just doing it to reassure myself. The patient's thinking, you think there's something there. You think there's something there, don't you? And you're not yet telling me you want this to tell me. You know what I mean? So there's real negatives in screening in the wrong situation. So we have to pick it correctly. And again, the evidence for screening people for pancreatic cancer at the moment is pretty limited. So and so what we do is we enter them into the Europac trial most of the time, which just involves there's a very straightforward protocol for how to follow those patients through. But it's a very small number of people.
And do you think that looking at the diabetic population is a good way of trying to move forwards with some of this? Is that somewhere where we can find some of these patients, or what's your thoughts around that?
I mean, the answer will be yes, but again, number needed to scan to identify one tumour is quite high, I think, at the moment. There is a national study, and I've completely forgotten its name right now, that is looking at that. So that there is a full protocol running. It will come to me later on, I'm sure. But yeah, they're looking at it. So in people with new diabetes, it isn't just everyone with new diabetes. I think you have to have other criteria. So if you've had weight loss for no good reason, or family history of pancreas problems, or there's a bunch of things that, if that's the case, they should have a CT, not everybody with new diabetes, because most people with new diabetes don't have anything at all to find in their pancreas, as simple as.
And
so
I think it gets a bit more complicated, doesn't it? Because then with new diabetes, often type 2, we're saying, can you lose weight? And patients are often very effectively losing weight.
Yes.
It feels like a minefield, very difficult.
I think that's right. So I think that's one of the tricks, isn't it? Is then how do you then
that apart?
How do you work that out? And people with type 1 or insulin deficient type diabetes will often lose weight as well. So yeah, not an easy call on that. And then given the number of patients that there are who develop new diabetes, and it's not infrequent, that's a lot of people you'd scan, possibly for not a lot of benefit. So yeah, I'll see at some point if I can find the name of that study, but that might be the way to do it. If you've got patients like that, maybe enter them into the enter into a study to look for it.
Yeah, really interesting. Thanks. Yeah, it's just so hard, isn't it? I think we've gone into this podcast and we're already identifying so many challenges around diagnosis. Just pivoting a little bit here to a slightly different type of tumour. Can I get your perspective on neuroendocrine tumours of the pancreas? I feel like they have quite a different presentation sometimes. Maybe they don't, but could you just talk to us a little bit about the presentation of them and some of the prognosis compared to adenocarcinoma?
Yeah, no, definitely. They are very different. So there's several parts. So one is they're a rarer version by a long shot. So the vast majority of cancers of or tumours in the pancreas are PDAC, as we call it, pancreatic ductal adenocarcinoma. There's then a whole bunch of other rarer versions of things, from something called a SPEN to various things. But neuroendocrine is not an infrequent one. We see a number of those per year. But they come from a different part of the pancreas. So as I said in the other podcast, you've got the kind of ductal bit that makes your lipase, and you've got a load of endocrine tissue, and they come from the endocrine tissue. Generally, they are more indolent, they have a better outcome, they're easier to treat, they're slower growing, but you have to work them up adequately. So the majority are non-functional, so they're just a bit of overgrown bit of neuroendocrine tissue. Some of them are functional, so you'll have heard of there's various functioning versions of tumours. So insulinoma is probably the most common of all of those. We've all heard of those. Basically, it's just producing insulin for no bloody good reason, gives people hypos and weight gain and all kinds of stuff. Difficult to sometimes work out what's going on, but when found and treated, do very nicely. And then there's like gastrinomas, vipomas, statinomas. Again, they're all quite unusual. Some of them have got these well-recognised syndromes, but the vast majority of neuroendocrine tumours are just a lump in the pancreas that aren't producing additional hormones. So they present as a mass. They often present as quite a discrete mass. They kind of sit quite nicely. They'd be any part of the pancreas. We biopsy them using endoscopic ultrasound to be sure. And really, it comes down to what their grade is, and we use something called the Ki-67. You might see that on reports. That's basically a proliferation index. So the higher that number, the more turnover there is in that tumour. Can be a bit patchy in the tumour, but there's grade 1, 2, and 3. So grade 1 is about 1 to 2% Ki-67, and then 2 to 20 is grade 2. That's quite wide, and anything over 20 is grade 3. Grade 3s are a bit more like a cancer and usually get systemic treatment. Most of them are grade 1 or grade 2, and if they're grade 1 and less than 20 millimeters, usually, and they're non-functioning, usually you've got, it's back to the kind of concept of the colonic polyp. You've got years before anything bad will happen. So they'll often go for observation. They'll get annual CT scans. If it starts growing or gets over 20 millimeters or something changes, then they'll resect. If it's grade 2 or greater than 20 millimeters, the evidence is they should probably be resected. Of course, this is all down to how fit is your patient again, isn't it? Because we're talking about things like Whipples or major pancreatic resections. These are not small operations, and the patient needs to be suitable for that. Some of them get treatment with what we call analog. So octreotide inhibitors, which I'm sure you've come across them. There's a whole bunch of different ones. There's short-acting, long-acting, and again, the top of my head, it's completely gone from what the hell they call that stuff. But we actually have a specific, so we have a pancreatic cancer MDT, we have a liver cancer MDT, we actually have a neuroendocrine one specifically. Because again, they're not just in the pancreas. You can get neuroendocrine tumours all over the body in lots of different types. Lanreotide, that's the stuff we tend to use. So that's the that's the long-acting thing. And what that tends to do is block any action it's got, but also kind of inhibits its growth. So these guys, they get worked up, they get biopsied, we stage and grade them. And again, many of them will just get observation. Some will get surgery. Some get treated if they're more advanced, like an actual cancer. But again, I think the types of things they can use are quite different. So there's different kinds of chemotherapy than you'd use in standard pancreatic cancer. I can even now use, there's something called lutetium therapy, which again, you may have seen some patients have. It's a way of using the receptors actually on the tumor, the neuroendocrine receptor specifically, and you can give an agent that's got something attached to it that basically homes in on that tumor and then attacks that tumor cell. So some very clever stuff they can do. But again, there are a relatively small number of those. And again, there's a number of other manifestations of neuroendocrine tumors. So people have always heard of the ones where you get, flushing and this kind of stuff. Most patients we see if it's just in the pancreas, you don't see that. That's more what we used to call carcinoid, which is not really the right term anymore. Neuroendocrine is the right term for it. But you can get them anywhere in the body. So you see them in luminal tube, you see them in any part of the gut, you see them in the lung, you see them in all over the place. So yeah, but even those people who've got metastatic neuroendocrine tumours still live a lot longer than you would if you had metastatic pancreatic ductal adenocarcinoma. Seems just to be a bit easier to treat. The treatments work more effectively, and patients have a longer survival in general.
Brilliant.
They'll also remove a lot more stuff. So if even if it looks like it's invaded other things, if they can take it all out, they'll take it all out. So I've had people who have they've had like their distal pancreas, their spleen, their left kidney, the left adrenal bit of the stomach, what I'd largely call a left upper quadrant ectomy, because they get all the tissue out, and that's quite morbid surgery. But if you get through that and they've rejoined everything, actually you might go on to live a lot longer life afterwards. So they'll be more aggressive because they've just got a better outcome. So yeah, if you're going to choose a tumor of the pancreas, choose that one, because most of the time you're not going to need anything done, and you'll just be watched, or you have a bit of lanreotide. That's about it.
And just coming to the end now, John, I'm thinking about kind of the future here. Okay, so how has the management of pancreatic cancer changed in recent years, and are there particular advances in treatment that are giving you hope of better outcomes for these patients?
Yeah, it's been pretty dismal. It has been for a long time. If you go onto the Pancreatic Cancer UK website, the 5-year survival 6% or something like that. It's awful. And for those who have surgery, it's only something like 25 to 30%. It's still pretty low. And what that really, really tells us is that this tumour is not as localised as we think. So there's been a large move towards giving systemic therapy, so chemotherapy, generally speaking, to most patients, whether they're getting an operation or not. The idea being, so we used to call it downstaging. It's a terrible word for what things are. It doesn't downstage. You're dealing with micrometastases. You always were. That's what adjuvant chemo does. So you go back to the old esophagogastric data. They used to do an esophagectomy, and they resected a bit of rib to get into your chest to be able to get to it. And actually, when they looked at that, you found cancer cells in the marrow of the bone. So that means it was all over the place. You just couldn't see it. So what the adjuvant treatment we thought was doing, and even neoadjuvant treatment, is actually dealing with those micromets that you can't see, i.e. small bits that have tried to branch out, kill them early, and then when you remove the primary, there's no other seeds knocking around. That's the idea. The problem we have in pancreas is that so far we've got very little in the way of very effective chemotherapy. So colorectal, breast, lung, even upper GI, very sensitive tumours, or particularly some of them very sensitive tumours to chemotherapy, whereas actually pancreas, not so much, even with newer regimens like FOLFIRINOX, which again is a chemotherapy regimen I'm sure you may have seen. It's got platinum in it and a whole bunch of other stuff. immunotherapy starting to come through, but again, I think the big problem with the pancreas tumours is that they're actually what we call paucicellular. So when you biopsy them, a lot of it is not cancer. A lot of it's kind of the stroma and the reaction around it, as opposed to cancer. And it causes so many other things. So when we manage these patients, they get a number of, so they may have jaundice, so they may therefore get a stent to treat their jaundice. But you've got to think the head of pancreas very often is sitting right by the stomach and the duodenum, so they get gastric outlet obstruction, they get a degree of pancreatic insufficiency, they often get diabetes. There's a whole bunch of things that's going on. And, thinking that one simple thing will sort it out is quite a multiple symptomatic and tricky condition, and it really knocks your nutrition very quickly. So they often lose weight in front of your eyes. I'm sure you've met these patients. They go from someone you'd seen 2 years ago, they walk in like a skeleton, you're thinking, oh crap, they melt away before you very quickly. So some people, even if they've got operable disease, aren't fit for the operation, because it's actually a hell of a thing to go through. As I said, Whipple's procedure has about a 30-40% morbidity alone and a 1 to 2% mortality. That's even in the best of units' hands. It's really hard to get down from that. It's just such a big operation, which is why it was centralized to big units to do lots of it and do it, or to try and do it as best as possible. So, what's changed? Well, we're trying to work on more rapid pathways. That helps in a way, but the problem is, once you've already got a mass in your pancreas, it's important to get patients through your pathway as fast as possible. But to be honest with you, you've got what you've got. What you wanted to do was detect it 4 months ago when it was smaller and more removable. The problem with some of these rapid pathways is they move everyone the same. I don't have a problem with that. People need to be seen and treated as fast as possible. But you're moving through people who've always got metastatic or unresectable disease very quickly. That's not a problem. But if you really want to get those people who are operable through, they need to perhaps be singled out somehow. And that's quite hard to do that. And it's hard to find those patients as well. So, the big change is now moving a bit more towards upfront chemotherapy. So 10, 15 years ago, 20 years ago, easily, if someone turned up with a mass in the pancreas or jaundice, they'd probably go for an operation, remove it. Oh, great, that sounds like a good idea. And then within 18 months, they've got recurrence. Well, that's because you haven't dealt with that underlying other bit of disease. And so the problem people sometimes is like, well, it looks operable now. And you're like, yeah, but we know what happens in 18 months' time. So if you give them chemo first, we're still trying to prove this, but we think that's likely to lead to better survival. It's also a bit of a test of biology, and we're getting this idea that not all tumours are the same. So, someone with a head of pancreas tumour, that's important it gets dealt with, but some progress faster and slower than others. Some will be more receptive than others. And actually, if you give someone, basically 2 cycles of neoadjuvant chemotherapy and they progress on that, well, isn't the chance that they were never going to do very well in the first place? So actually, it's been a good test of biology to see what happens to them. Whereas if you give someone, you get somewhere it shrinks away, you think, brilliant, this is chemosensitive disease, an operation would be great. So we'll remove the primary and actually we'll take care of the rest of the disease. So a lot of what we're really waiting for is that breakthrough they've had in other cancers where they find an agent that works on a lot more of the cancers than it currently does. So most patients present to us, unfortunately, as either locally advanced. So there's about 3 or 4 different groups. So there's purely operable, i.e. you've got a lump, it's away from everything, it could be removed quite straightforwardly. You've got locally advanced, and what we mean by that is it's, it looks like it's attached to something pretty important, like one of the major arteries. Probably not going to operate on that straight away because 1, you won't get it all out, and 2, well, why would you want to do that? And then there's metastatic. Now, metastatic is quite obvious. It's usually to the liver. They're palliative. There's also borderline resectable. And what we mean by that is the kind of one where you think if you give it a bit of chemo and it shrank back a bit from that vessel, that might be able to come out. And they're another group that you want to identify those. There's maybe about 10, 15% of the patients turn out to be that. But currently the response rates to the chemo are so, not great, that even if you find that, you kind of, you wouldn't operate on them now, but you're kind of hoping some of them respond, and some do. So they're the kind of groups. But there's so many other things to manage. So we commonly talk about managing their exocrine insufficiency that blocked off the pancreatic duct. I mean, to be honest with you, the evidence for using enzymes in this group isn't as good as you might think it is. But it's not an unreasonable thing to do. Sometimes you have to manage the diabetes. They get quite aggressive form of diabetes because they become diabetic very quickly, often progress onto insulin. That's a bit of a mind job when it may account for some of their weight loss, but all this is going on. If they've got jaundice that needs managing, sometimes operatively, that's what a Whipples will do, but very commonly these days via endoscopy, we tend to need to do a biopsy. So we do a lot of kind of one-stop shop. So if someone turns up jaundiced, we go down with an endoscope, take a biopsy, then change to a different endoscope and put a stent in, do that all in one set of sedation and sort it all out. You also don't need to be in hospital for this. So, jaundice is one of these things that used to get people admitted all the time. If you can get tests rapidly enough, being yellow doesn't mean you need to be in hospital. Now, sometimes it does, don't get me wrong. But most people with a cancer don't get cholangitis. They tend to have a sterile obstruction. And it's only when we fiddled with it that it then gets we contaminate it. So if you're just a bit yellow and itchy, do you need to be in hospital? And again, it'd be interesting to know what your access to things like rapid access jaundice clinics are, because they're patchy. I don't think everyone has them. But that'd be the kind of thing you need, is don't admit them to hospital because they're going to sit around for a couple of days while we do scans and this, that, and the other. Jaundice clinics are great. You get seen, you get your bloods done, you get a scan done at the same time, whether it's ultrasound or CT. And then if we confirm that you then go through the MDT, and the following, if you get that on the Wednesday, you get your scan on the Thursday, you can get your ERCP on the Friday. So actually, you don't need to be in hospital at all. It's a much more efficient use of everybody's time. And you get a diagnosis, see a surgeon, see an oncologist, see whatever you need to get done. But again, we've started to advance the way we're managing these things endoscopically. So we've got some more advanced ways of draining jaundice. And even on Friday, for example, we're going to be doing an endoscopic gastrojejunostomy. So what used to be an operation, we can now do down an endoscope. It's quite a clever way of doing it down endoscope, don't get me wrong. But there are definite ways of I don't want to say preventing surgery, because that sounds like I don't like surgeons. I work with them very closely. But using surgery appropriately. So there are alternatives to stents, and there are ways of improving patients' symptoms by using more advanced endoscopy techniques, for example. So there's a lot to manage in these patients, and pain, again, can sometimes be very difficult in these kind of patients with pancreatic cancer. It's actually interesting how a lot of them don't have that much pain often to start with. It's when it starts to invade into stuff. Again, we tend to go for opiates. I've not been, again, that convinced that this is as good as we think it is. An adjuvant, other agents, I think, are useful. And we do not an infrequent number of celiac plexus blocks or neurolyses. So particularly in someone who's never get an operation, so we're talking the more palliative person who maybe, going to see the palliative care people for pain relief. Always think about whether you can do it, because we can do it via endoscopic ultrasound. We can find the celiac axis and put a whole load of we use one of two things. So we inject some local anesthetic, and then you can either use steroids, or in these cases, they tend to use absolute alcohol just to ablate their superior nerve, and it's very good for pain and can help de-escalate some of their opiate use. Because you imagine opiates, they can be good for pain, but you get constipation and all kinds of other stuff related to that, and I'm sure I don't need to tell you that. So if you can de-escalate some of their pain meds, it actually helps some of the other symptoms. So there's a bunch of different stuff to manage in these patients, and we get very excited about trying to get them to surgery. Majority who don't get surgery, and what we don't have are people who take a lot of interest in those who don't need an operation. Because oncology's idea is to give them chemo. That's fine. But again, there's a bunch of them who won't be suitable or don't want it. So what treatment are they getting? And there's other things that need to be done. So are we managing these other areas, like I'm saying? It can be quite difficult to get that right, I think. And nutrition, I think, is a big deal in these patients.
It's a huge topic, isn't it? And there's so much there around treatment and different things that are going on, but it's all really focusing on getting in early, isn't it? And trying to identify these patients. And I think, we've discussed it. The challenge is really there. We've come to the end, John, of this podcast, and what I'd like to do is give you the opportunity to kind of talk to our primary care audience, and which you've been doing fantastically already, but just to kind of your kind of key take homes. So there's sort of a couple of key take homes that you'd like our GPs to leave this podcast, either based on what we talked about in part 1 or on part 2. You'd really like them to go away with? What sort of real take homes have you got that you want to impart?
Wow. Okay. Yeah. Well, pancreas stuff. I think the big area, the big thing about pancreas is it's a bit of one of those kind of Cinderella specialties within medicine, isn't it? So most people are pretty good at cardiology, respiratory, even endocrine, and primary care. You're very good at that kind of stuff. And even within gastroenterology, you guys manage quite a lot of stuff very well. Pancreas scares the crap out of everybody, and it shouldn't. So most of these things, I'd say break it down. So it always seems complex, but actually complex things are generally lots of simple things. They just happen to have happened all at the same time. So break it down. So whether it's chronic pancreatitis, whether it's pancreatic cancer, what are the issues? So pain. Okay, well, you guys are great at pain. I don't need to teach you about managing pain. But again, like I said, for the chronic pancs, nerve-ending pain blockers are possibly better than opiates. And again, in the chronic pancs, we'll think about things like celiac plexus block, particularly, pancreatic cancer, celiac plexus block. Because actually it can be really very useful in the right patient. Not everyone's suitable, and you shouldn't do it in someone's operable, but they'll be the people to look at. The main thing in the pancreas is to think, could it be pancreas? I think that's often the thing that people don't even think. They're going through a whole bunch of different symptoms with patients. And because in the end, the gut's only got so many things it can do. When you've got bellyache and diarrhea, I mean, how many different things is that? That's hundreds. That's why it's difficult to work out what's going on. The symptoms are no help. I mean, they are, but they're nowhere near specific enough, are they? And so, have a reasonably low threshold to consider imaging. So whether it's if you're worried someone might have pancreatic cancer or worried they might have chronic pancreatitis, a CT scan be really helpful, because if they don't, then brilliant. And it's no bad thing to do. Think about that for age. If they're 20, maybe not so much. But if they're over 50 and you're a bit concerned, I don't think there's a problem with that. I mean, I get GPs write to me all the time, and I'm very happy to write back with advice or see a patient or whatever it might be. I think that interaction with your secondary care or tertiary care providers is really important. I'm sure it's a bit variable in different places, and I see this even when I speak to people like dietitians in secondary care settings. I'm a fairly specialist person in what I do. There isn't someone like me absolutely everywhere. So sometimes your more general gastroenterologist doesn't have as much experience of pancreaticobiliary stuff, and that's okay. And sometimes you might need to go and find someone like me. There are people like me all over the country, but identifying that person isn't always very easy. And we are often a little few and far between. As I said, Cinderella type specialty. Break it down is my biggest advice. So if it's pain, deal with pain. If they're jaundiced, deal with jaundice. What if it's nausea, if it's diabetes, you're very good at diabetes. If you think they might have PEI from any of the causes, investigate that, image them, have a reasonably low threshold to try them on some enzymes. I don't like the concept of a trial of enzymes, because actually some people get better when you do that, but actually it's probably placebo, so it's not that on its own isn't a test for it. But if you've got someone who's got chronic pancreatitis and GI symptoms, well, that's fine. Or someone who's got, they've had half the pancreas removed and they've got GI symptoms and on enzymes, well, it makes sense to do so. Break those things down. And I guess the other thing is that these patients often are complex, and actually we did something called a PSP, which is a partnership thing with patients and family members. It was about 18 months ago, and they've done this in other areas. And what was interesting, we were trying to find out what the top 10 research priorities were in pancreas diseases, and that included, it was in pancreatitis, it wasn't in cancer. And what was amazing, what came out of that was, I thought, were things that we knew the answer to, and actually it turns out we often don't. And this is the patient's perspective of saying these things we feel are unanswered. So education was a big one, in that it was very common that people went to hospital, and even if they knew they had some kind of pancreas problem, the people there didn't even know what they had and didn't know how to manage it, and they assumed it was all due to alcohol. So please don't assume everyone with pancreatitis is an alcoholic. Absolutely don't do that. Same as liver disease, because if they aren't, they'll get incredibly angry with you, and you can understand why. And in acute pancreatitis, the most common cause is gallstones. It's not alcohol by a long shot. And the same even in chronic pancreatitis, only about 30% of them have actually got alcohol-related problems. So it is not the most common cause, despite what people think. You might see a lot of those patients because they can be troublesome, don't get me wrong. But there are a lot of causes that are nothing to do with alcohol whatsoever. Do not make that assumption. And in fact, most of the time, by the time they see me, they know that's what it is and they've dealt with it. So, yeah, have a low threshold to chat with someone about these things. They're complicated things. Education is important, and break down the different parts of what's going on. And, as I say, never be afraid to ask for advice. These are difficult patients with complicated, often quite unusual conditions. So, yeah, feel free to phone people up and ask. And sometimes just a phone call or an advice and guidance, or even a letter in, can be really helpful. And again, I'd say in the chronic pancs, don't forget their bone mineral density. What I would say is the FRAX score is useless in those groups. So don't do the FRAX, just just measure their BMD.
Brilliant. Well, that's a great note to finish on, John. And from my perspective, one of the key things that I've taken away is kind of think pancreas, because that abdominal pain could be due to pancreas, or that presentation, that diarrhea. We just got to think about it. And it's similar with quite a lot of conditions. It's just about, you got to think about it. It's got to be there in your mind, otherwise you just won't consider it, and we need to be considering it. And also that really holistic approach. Actually, I think primary care probably is a really good place for these patients to be managed, actually, in many ways, with support from secondary care, because we are very good at managing pain in primary care. We do it all the time. We've got the diabetes side of things. There's lots of things that actually we can bring to the table in primary care, working in conjunction with our secondary care colleagues. I
don't do much diabetes at all. So you guys manage diabetes on a routine basis. Actually, it was a year ago I got diagnosed with type 2. I've had my thing come through today saying you need to come back for your annual review. That's my GP doing that. I've never seen anyone in secondary care because I don't need to. I've lost 3 stone. I think that's what's probably helped. But you're right. What we underestimate. So it's that ivory tower thing, but we underestimate how good primary care is. I actually personally think it's the hardest job to do well. It's a very easy job to do badly. But it's the hardest job to do well because you actually have to be up on nearly everything all the time. Now that's a lot of different things. You don't have to know everything about everything, but these days you seem to need to know quite a bit about most stuff, and I think that's the problem. That's very hard to do. So I'm always very impressed with what the GPs do. But yeah, for a lot of the gastro and pancreas related stuff, other than our interventions and surgery or chemotherapy, for example, most of it is about things like, pain relief, diabetes management, enzyme provision, and some other symptom management. That isn't something that you couldn't do in primary care. But you've got to understand what it is you're doing with those patients and why and how.
Brilliant. Well, John, look, thank you so much for joining me. You've been so generous with your time, so thank you very much. And to our audience, thank you for joining us. I hope you found this a really interesting episode, exploring pancreatic cancer. This is obviously part 2. So if you haven't listened to it already, go back to part 1. John will talk to you all about non-malignant causes and conditions within the pancreas. If you've enjoyed this episode, please click subscribe. It's great for you to do that, and then we'll notify you whenever we bring out an episode. And we love feedback. We really love to hear from you. We love to hear about different episodes that you'd like us to do. So if you want to provide feedback, you can do that either through the Primary Care Society for Gastroenterology website or on Spotify. Let us know what you think. We're always really interested. So thank you very much, everyone, for joining us, and thank you so much, John.